Blood component transfusion. This is an era of blood component transfusion. The transfusion of a whole blood is very rare today. The blood component or transfused separately or in combination depending upon the need of patients. The transfusion of blood components should be preferred over the transfusion of whole blood. This is due to the following reasons. Separation of blood into components allows optimum survival of each constituent. Two, it is possible to transfuse blood component as per the need of patients. It avoids the use of other unnecessary component which could harm the patient. Three, by using the blood component, several patients can be treated with the blood or from one donor, giving optimal use of every unit of donated blood. Thus, blood component transfusion achieves a most effective way of optimum, safe, and economical use of blood. The various blood components that can be separated and transfused are shown in the table. Cellular component, plasma component, plasma derivative, cellular RBC concentrate, leukocyte reduced RBC, platelet concentrate PC, leukocyte reduced PC, platelet apheresis, granulocyte apheresis, plasma component, fresh frozen plasma, single donor plasma, cryoprecipitate, cryo poor plasma, plasma derivatives, albumin 5% and 25%, plasma protein fractions, factor 8 concentrate, immunoglobulin, fibrinogen, other coagulation factor. These components have highly specific and regulated preparations and storage requirements. The blood group compatibility between the component and the patient is considered during the transfusion. Each component carries the same risk of transfusion transmitted disease as that of whole blood. In contrast, the plasma derivatives fractions such as albumin, immunoglobulin, immune serum globulin, and concentrated coagulation factor, etc., have more flexible storage requirements and are given without regard to ABO compatibility. These fraction also carries a decreased risk of transfusion, the transmitted disease. The plasma derivatives are prepared by biochemical or other manufacturing conditions in well-equipped plasma fractionated laboratory. Preparation of a blood component is possible due to multiple plastic pack system, refrigerated centrifuge, different specific gravity of cellular component. The red cell specific gravity 1.08 to 1.09, platelet specific gravity 1.03 to 1.04, plasma specific gravity 1.02 to 1.03. Due to the different specific gravity of cellular component, they can be separated by centrifuging at different centrifugal force in grams from different times. Centrifugation of a blood component preparation. The refrigerated centrifuge rotor speed and duration of spin are critical in preparing component by centrifugation. Each centrifuge should be calibrated for optimal speed and the time of spin for preparations of each component. The time given here includes only the time accelerated and its speed, not the deceleration time. The blood component are prepared by centrifuging at different relative centrifugal forces in grams at different times. The conversion of a relative centrifugal force RCF to rotation per minute depends upon the radius of a centrifuge rotor. It can be calculated by relative centrifugal force in gravity, RCF into G for preparing component. Therefore calculation RCF is equal to 28.38 into R into RPM divided by 1000 square. Precaution to observe the preparing components in blood collections, the proper donor selections and vein puncture. Vein puncture to minimize the bacterial contamination and tissue trauma. Correct amount of blood in proper anticoagulate and mix it properly. The blood should be collected in primary bag that has a satellite bag attached with the integral tubing. A triple pack system with two attached bags makes it possible to make red cells, platelet concentration, fresh frozen plasma, while quad pack system with 3 attached bag are used for preparing red cells, platelet concentration, cryoprecipitate, factor 8, and cryo poor plasma. Double bag are used for making red cells and plasma only. In centrifugation, one opposing cup with the blood bag and satellite bag must be equal in weight to avoid irregular wear and tear and eventual breakaging. If any abnormal variations is observed till required speed is attained, stop the centrifuge and check the weight of the opposite cup with bag. Rubber disc should be used for balancing. 2. The bag should be so placed that its broad side faces outside wall of the cup. 3. Correct speed of centrifuge and the time must be maintained. Centrifuges used for separation are calibrated to produce the highest product yield in the shortest time at a lowest possible spin, so as to cause the least trauma to each product, and at the same time maintaining the optimum temperature for the component viability. It is the unit of blood. The centrifuge product is settled in layers starting from the bottom: red blood cells, white blood cells, and platelet rich plasma. Whole blood, the whole blood containing 450 plus 45 ml or 350 plus 335 ml of blood donor plus anticoagulant solution. The name of anticoagulant is used with the name of the product. Example: CPDA. The whole blood has a hematocrit or 30 to 40 percentage. Minimum 70 percentage of transfused red cells should be survived in the recipient's circulation 24 hours after transfusion. The stored blood has no fraction platelet and no labile coagulation factor 5 and 8. 2. Red cells. The red cells can be transfused in the following different forms: packed red cell blood. When red cell are separated from the plasma and used for transfusion, they are called as a packed red cell. There is a need to transfuse packed red cell in case of decreased bone marrow productions like aplastic anemia and leukemia. 2. Degrees red cell survival like hemolytic anemia and thalassemia. 3. In bleeding patients, surgical or traumatic bleeding, the packed cell transfusion is especially used in cases with congested cardiac failure to reduce the load on heart by reducing the volume. Also, the packed red cell transfusion less severity and incidence of allergic reaction. It is proven that the packed cell are equally effective as whole blood when use of transfusion is elective surgery, saving the plasma for fractionation. In case of emergency or group specific shortage, when O blood group is used, it is advantageous to use packed cell as a plasma with antibody is removed, the minimizing the risk of hematolytic reaction due to the anti and antibody. The packed red cell are obtained from the whole blood either by centrifugation or by gravitational sedimentation, where it is allowed to sediment during the storage. Sedimentation: the blood after collection is kept upright in the refrigerator at 2 to 6 degrees centigrade. The red cells settle down and clear supernatant plasma is transferred into the satellite bag. The sedimented RBC have 30% plasma and all original leukocyte and platelet. Centrifugation: collect appropriate volume of donor blood in CPDA, a double or triple bag, store at 2 to 6 degrees centigrade till processed. Place the bag in buckets of refrigerated centrifuge and balance in opposite bag accurately. Centrifuge at a high spin 5000 into G for 5 minutes. At 2 to 6 degrees centigrade, express approximately 3 by 4th of the plasma into the satellite bag. Double seal the tube between the primary and second satellite bag with plasma. Separate the satellite bag with plasma and keep it at 30 degrees centigrade or below. Keep the red cell at 2 to 6 degrees centigrade. This sedimented RBC have 15% plasma and all original leukocyte and platelet. The increased viscosity of a packed red cell may result in significantly reduced infusion rate and poor cell survival in storage. To reduce the viscosity and also prolong the red cell shelf life, circle packs with additive systems SAGM, ADSOL, etc. or additional of 50 to 100 ml of normal saline just prior to the transfusion may be helpful. For a single use of a packed cell, the hemoglobin is raised by about 1 gram per deciliter and HCT by about 3% of total pre-transfusion HCT value. The provided patient is not bleeding from any side. B. Saline washed red cells. The saline washed RBC are free of almost all traces of plasma, most WBC and platelets. They are generally given to the patients who have severe reactions to plasma, like severe allergies, paroxysmal nocturnal hemoglobinuria or IgA immunization. To prepare this, red cells are first separated without the buffy coat and then washed with saline in order to remove most of the remaining white cells. The washing of the cells can done manually or with the use of machines. Hemonetic cell washing machine. To pack the red cells should be diluted and mixed with the saline centrifuge, and saline supernatant is removed. The procedure is repeated for 3 times. This procedure removes 70 to 95% of leukocyte and effectively removes plasma protein and micro aggregates. The washed red cells have to be used within 24 hours. The process is done with aseptic precautions under laminar process. See, leukocyte poor red cells, WBC depleted RBC. The leukocyte poor red cell transfusion is needed in case of multi-transfused or and multi paras patients like thalassemia, leukemia, aplastic anemia, immunosuppressed or immunodeficient patient. These patients get a febrile reactions with any transfusion of packed cells and hence require the leukocyte poor red cell preparations. This implies that nearly 70% of leukocytes are removed and over 70% of red cells are retained. This can be prepared by inverting the centrifuge, washing or freezing cells, and by use of leukocyte filters of pore size 20 to 40 microns. These filter can remove approximately 99.99% of WBC with little loss of RBC. They are indicated for patients who have experienced non-hemolytic febrile transfusion reactions or for exchange transfusion. The inverted centrifuge is also simple and helps to reduce the number of leukocytes by avoiding the buffy coat from the packed cell preparation. In this method, the red cell or centrifuge in an inverted position so that the red cells can be transferred into the satellite bag, leaving buffy coat, some red cells and plasma in the primary bag. This method of reducing leukocyte by 70 to 80 percentage and sacrifices 20% of WBC. It is also a laborious method, therefore it is mostly replaced by the filter. The leukodation can be done of three different points: pre-storage reductions, after storage leukoreduction in blood bank, before issue blood side filtrations. Frozen cell. The frozen cell can improve cell surveillance and increase shelf life to 5 years and above. They are useful in the storage of rare blood group cells and blood for autologous transfusion. Frozen cell prevent autoimmunization. The disadvantage is its enormous cost and time laborious involvement. For freezing red cell are used within 6 days of collections. The widely used high glycerol technique employs a final glycerol concentration of 40% weight by volume. To standardize use unit of a packed cell, 100 ml of glycerol is added at a room temperature with the constant mixing. After 5 minutes equilibration, another 200 ml of glycerol is added. The unit is kept in metal or cardboard container and stored at 65 degrees centigrade and or lower. The storage period for routine use is limited to 3 years. For use unit is thawed at 37 degrees centigrade in water bath with agitation. 12% of NaCl solution is added and mixed for 5 minutes. Then NaCl is decanting grade is used for washing cells. The final cell concentration is suspended in 0.9% of NaCl and 0.2% dextrose. This deglycerolized unit has a shelf life of only 24 hours. Neocytes are the young red cells. The transformation of this is desirable in young patients with severe chronic anemia. Example, the thalassemia patients who require repeated transfusion. Each ml of RBC contains about 1 milligram of iron, which is theoretically can be deposited in the tissue and causes hemosiderosis. If neocytes with an average of 90 days lifespan are transfused instead of conventional RBC with an average 60 days lifespan, the RBC transfusion requirements and the chance of inducing the hemosiderosis may be reduced. The younger cells are larger and less dense, and hence the collection of upper half of the unit may contain more of young cells. This can be procured more effectively with the use of cell separator machines. Because of high cost of neocyte separation and the time consumption, laborious procedure, the initial enthusiasm is now dwelling. Platelet transfusion. Platelet are the primary importance to maintain normal hemostasis. The need of a platelet transfusion is a indication for platelet transfusion when platelet count is less than 5,000 per microliter, regardless of clinical condition. Platelet count is 5,000 to 10,000 microliter if there is increased risk of bleeding due to the hematological malignancies, sepsis, severe aplastic anemia, or patient undergoing bone marrow transplant. Patient platelet count is 10,000 to 20,000 per microliter if the thrombocytopenic bleeding is present. The thrombocytic bleeding, microvascular bleeding, is bleeding from the mucous membrane, oozing from the surgical incision, bleeding from the vein puncture site, scattered petechiae, and chemosis. Chemotherapy for malignancy decreases the protection if the platelet is less than 20,000 per microliter. Increased destruction, DIC, increased destruction if platelet count is approximately 50,000 per microliter. The massive transfusion, platelet diffusion, if the platelet count is less than 50,000 per microliter. The major surgery, if in emergency, if the platelet count is 70 to 80,000 per microliter. In addition, the platelet are indicated prophylactically from the patient who have platelet count 20,000 microliter to prevent bleeding. Two platelet products are available for transfusions. Platelet obtained from the whole blood, known as a platelets, or random donor platelet, and platelet obtained by the apheresis is known as a platelets. The pheresis or single donor platelets. Random donor platelets or whole blood derived platelets obtained by centrifugation of whole blood within 6 to 8 hours after collection. The blood is subjected to low centrifuge force, light spin 2000 xg for 3 minutes at room temperature 20 to 22 degrees centigrade to obtain the platelet rich plasma. This plasma is then separated from the red blood cells in satellite bag, and the unit is recentrifuged at a high centrifugal rate, high spin of 5000 xg for 5 minutes to concentrate the platelet. The majority of the platelet is expressed into a separate bag, platelet poor plasma, leaving a residual volume of approximately 50 ml plasma in which to resuspended the concentrated platelet rich plasma. The platelet may also be prepared after centrifugation to create a puffy coat containing the platelet, the leukocyte, and some red blood cells. A method used mostly in Europe. A buffy coat is then centrifuged at a low centrifugal force to concentrate the platelet. The stored platelet at a 20 to 22 degrees centigrade under constant agitation in platelet incubator with agitator till use. A random donor platelet preparation should contain at least 5.5 into 10 to the power of 10 platelets per 50 ml units and have a pH of 6 or greater. The shelf life of this product is currently 5 days. 1 unit of platelet concentration should elevate the platelet count by approximately 5,000 to 10,000 liter in recipient weight 70 kilograms. Platelet periphesis. The advent of apheresis instrument have facilitated the collection of a product from the single donor. Platelet periphesis yield a product equivalent to 10 random units. Platelet collected by the periphesis should contain at least 3 into 10 to the power of 11 platelets suspended in approximately 300 ml platelets and are stored in the same manner and have same shelf life as random donor platelets, provided the integrity of a system has not been compromised. Calculation of platelet yield. The number of platelet in whole blood is equal to platelet per millimeter cube into 1000 into volume of the whole blood. Volume of the platelet in PRP is equal to platelet per millimeter cube into 1000 into volume of PRP ml. Number of platelet in PC is equal to platelet per millimeter cube into 1000 into volume of PC per ml. Therefore, calculation is equal to percentage of yield in PRP is equal to number of platelet into PRP into 100 divided by number of platelet into whole blood. Percentage of platelet yield in PC is equal to number of platelet into PC into 100 divided by number of platelet in PRP. Fresh frozen plasma. The fresh frozen plasma is an unconcentrated source of all clotting factor except platelets. It is prepared from the whole blood and it is frozen within 6 to 8 hours of collection. Indications: the correction of bleeding secondary to factor deficiency for which specific factor replacement are unavailable. Multi-factor deficiency state, example: massive transfusion, disseminated intravascular coagulation, DIC, liver failure, and urgent warfare reversal. The FFP can supplement RBC when whole blood is unavailable. For exchange transfusion, FFP should not be used simply for volume expansion. The procedure: to prepare a fresh frozen plasma, centrifuge the whole blood collection with anticoagulant at a high spin of 5000 into G for 5 minutes at 4 degrees centigrade. Remove the about 2/3 volume of plasma into the satellite bag. Seal the tube. Separate the bag. The bag should be rapidly frozen within 1 hour. It can achieved by spreading the plasma in thin layer bag laid flat, not vertical, in freezer at -70 degrees centigrade, or placing the bag protected by plastic cover wrap at -70 degrees centigrade in ethanol dry ice bath. Once frozen, it can be stored at or below -30 and can be used for 1 year. The formation of cryoprecipitate containing factor 7 1C, fibrinogen and fibronectin, should be avoided during the thawing, as it would reduce the expected clotting properties. Thaw it in plasma defroster, microwave, or place the bag in plastic over wrap and put it in a 37 degrees circulating water bath. The entry port of the bag should remain over the water. The FFP should be administered as soon as possible after thawing, and in any event within 12 hours if kept at 2 to 6 degree. The most common dosage of FFP is 10 ml per kilogram of body weight. Cryoprecipitate are the precipitated protein of plasma rich in factor 8 and fibrinogen obtained from a single unit of fresh plasma, approximately 200 ml, by rapid freezing within 6 hours of collection. It is rich in factor 8, von Willebrand factor, fibrinogen, factor 13, and fibronectin. Indications for hemolytic and non-Willebrand disease. The cryoprecipitate is currently used as a source of fibrinogen in acute DIC with bleeding. The treatment of uremic bleeding, cardiac thoracic surgery, fibrin glue, obstetric emergency such as abortio placentae, and help hemolysis, elevated liver enzyme, and lower platelet count syndrome. Rare factors 13 deficiency. Several factors which improves the yield of factor 13 in cryoprecipitate are clean single vein puncture at the first attempt, rapid flow of blood, donation of blood 450 ml obtained in less than 8 to 10 minutes should be used, adequate mixing of blood and anticoagulant, rapid freezing of plasma as soon as possible after collection. In any case within 6 to 8 hours after collection, as done for preparing FFP. Rapid thaw at 4 degree is in centrifuging water bath. Use of siphon technique, which prevents the thaw plasma remaining in contact with the cryoprecipitate. Procedure: prepare fresh frozen plasma FFP as described under FFP for preparing into the cryoprecipitate. Freeze the plasma at -70 degrees centigrade in freezer or ethanol dry bath. Thaw frozen plasma either at 4 degrees centigrade in cold room, air thaw, or at 4 degrees centigrade in circulating water bath. If FFP is thawed in cold room, hang the bag in an inverted position with the port lower most and place the second satellite bag on the lower shelf. Observe the pack frequently to make sure the thaw plasma is flowing into the satellite bag and not accumulating in the primary bag. When 10 to 11 ml of plasma remains with the cryoprecipitate, seal the tubing and separate bag. If FFP is thawed in 4 degrees centigrade water bath, centrifuge the bag when the plasma is slushy at 5000 xg for 5 minutes at 4 degrees centigrade. Then suspended the cryopore plasma in siphonated out in the satellite bag, leaving 10 to 15 ml of plasma with a cryoprecipitate. Seal the tubing and separate the bags, label bags. Store the bag with cryoprecipitate at 30 degrees centigrade or lower, and the bag with cryo poor plasma in second satellite bag is stored at 20 degrees centigrade or below. The storage and shelf life of a cryoprecipitate 1 year at minus 30 degrees centigrade or below. Reconstituting cryoprecipitate. The thawing and issue cryoprecipitate. Reconstitute cryoprecipitate before issue by placing in an over wrap in a 30 degrees centigrade water bath until the cryoprecipitate has dissolved. The cryoprecipitate should be resuspended thoroughly by gentle needling. After thawing, pull the cryoprecipitate from all thawed bags into one bag under laminar flow by means of a bag-to-bag connector. Wash the empty bag with 10 ml of normal saline to dissolve residual cryoprecipitate and add pooled cryoprecipitate. Once thawed, the cryoprecipitate should be kept at 2 to 6 degrees centigrade and administered within 4 hours. It should not be frozen. One bag of cryoprecipitate contains on an average of 80 to 120 units of factor 8 in 15 to 20 ml plasma. Granulocyte. Granulocyte may be transfused when sepsis occurs in patient with prolonged persistent neutropenia, WBC less than 500 micrometer, who is unresponsive to antibiotics. These can be obtained by centrifugal leukapheresis and filtration leukapheresis. These are stored at room temperature 22 to 24 degrees centigrade and should be used within 24 hours of collection.